Hello toppers. Let's move towards the surgical conditions of gallbladder. Today we will be discussing about congenital anomalies of gallbladder and gallstones. There are many congenital anomalies. First one, absence of gallbladder. This is the rarest condition. Next comes double or triple gallbladder. As the name suggests, we will be having additional gallbladders with the normal gallbladder. Here cystic duct and common bile duct may be single, double or triple. Next, mobile, floating or mesenteric gallbladder. Here also, as the name suggests, mesenteric gallbladder. Here the mesentery will be very long, so it may cause torsion. So gallbladder will not be fixed in a single position. So because of the torsion, patients may present with recurrent abdominal pain, and it's an emergency surgical condition. Next, absence of cystic duct or long cystic duct. Next, accessory cholecystohepatic duct, which means duct of Laska. Nearly 10% of people is having this condition. If we won't able to identify this condition, it may lead to biliary fistula, peritonitis because of the continuous leakage. And other than this, we can have some arterial malformations like a cystic artery may originate anteriorly, posteriorly like this. So arterial malformations may also occur. Next, this is pyregian cap. In this picture, we can able to see that the cap like projection over the fundus of gallbladder. This is nearly seen in 6% of people. I hope in this picture we can cover all the congenital conditions. Normal gallbladder, first one. Next, low insertion of cystic duct into common hepatic duct. In this picture we can get absent cystic duct and everything. And in this picture we can able to see double cystic ducts are there. So they are forming the gallbladder and joining the common bile duct. Second one, this is pyregian cap. Next, this is the duct of Laska, which means accessory cholecystohepatic duct. Fourth one, this is gallbladder diverticulum. And the next one, double gallbladder. In this picture it has separate cystic ducts, but it can be double cystic duct or it can present with single cystic duct also. Next condition, choledochal cyst. Choledochal cyst, this is nothing but congenital dilatation of extrahepatic or intrahepatic biliary tree. It can be isolated, focal or combined. And this is a congenital cyst with a partial or complete weakness of CBD biliary wall. It can be single or multiple, and this is more common in Asiatic people and Asia people, and often this is associated with pancreaticobiliary maljunction. Next comes Babbitt theory. What Babbitt theory says about? Actually, because of this choledochal cyst, there occurs the reflux of pancreatic juice into the bile duct. So in that juice we are having many enzymes, so those enzymes will destruct the bile duct wall, so that lead to ductal wall weakening and dilatation. So this is what Babbitt theory says about. There are many types of choledochal cyst, nearly 5 types. First one is dilatation of extrahepatic biliary tree. Second type, diverticulum of extrahepatic biliary tree. Third one, choledococele, which means cystic dilatation of intraduodenal part of CBD. Fourth one, dilatation of extra and intrahepatic biliary tree. Fifth one, dilatation of only intrahepatic biliary tree. Actually, this type 5 is known as Caroli's disease, which means dilatation of only intrahepatic biliary tree. So these are the types: extrahepatic, diverticulum, intraduodenal, intrahepatic and extrahepatic. Next, only intrahepatic. And this condition is common in females, nearly 4:1, and present in infants, children, even it can be seen in adults. It causes obstructive jaundice, pain in right hypochondrium, mass per abdomen, and everything. And we have a triad in choledochal cyst, which is right upper quadrant pain, jaundice, and mass. Next comes an interesting thing, swelling which appear and disappear. There are four swellings which can appear and disappear itself. They are hydronephrosis, intussusception, pseudopancreatic cyst, and choledochal cyst. We have a mnemonic to remember this: C-HIP. C for choledochal cyst, HIP for hydronephrosis, intussusception, and pseudopancreatic cyst. And if we think about the complications, pancreatitis is the most common complication and it occurs mainly in type 3. And suppurative cholangitis, gall stone formation or CBD stone formation, biliary cirrhosis can occur, cholangiocarcinoma can occur in nearly 30% of cases. And if malignancy occurs, that is more common in posterior wall. Next comes Caroli's disease. As we have already saw, this is type 5 choledochal cyst, intrahepatic, and this is associated with congenital hepatic fibrosis and medullary sponge kidney. Next, biliary atresia. Biliary atresia, here we can able to get fibrosis of extra and intrahepatic biliary tree. Incidence is very low, 1 in 10,000 people. And there are many causes like infections, immune and autoimmune diseases, embryological causes, toxins, and vascular defects of hepatic artery. And nearly 90% of the cases are non-correctable and nearly 10% will be correctable. Next comes the types of biliary atresia. Type 1, 2 and 3. Type 1 atretic CBD. Next atretic CBD and common hepatic duct. Third type atretic CBD, common hepatic duct and right and left hepatic duct. And this type 3 is the most common one. And it can be perinatal or embryonic. Nearly 70% of the people are present with perinatal period and they are not associated with congenital anomalies. But fetal or embryonic is associated with congenital anomalies like malrotation, annular pancreas, duodenal atresia, congenital heart disease, like this. And the clinical features can be progressive jaundice in a newborn, steatorrhea, and pale stool is the common feature. And there are some organomegalies like hepatomegaly, splenomegaly with portal hypertension, osteomalacia, biliary rickets, severe pruritus, clubbing, and skin xanthomas. Because these features are mainly seen in all congenital anomalies and congenital cardiac diseases, so they will be having clubbing and skin xanthomas also. And on liver function test, we can get conjugated hyperbilirubinemia. And US abdomen shows triangular cord tubular echogenicity extending above the bifurcation of portal vein. That is diagnostic. And MRCP is having 100% accuracy. Next comes gallstones. They can be cholesterol stones, pigment stones, and mixed stones. And these mixed stones are more common. Nearly 90% of stones are mixed stones. And cholesterol stones are often solitary, but mixed stones are often multiple. Also, multifaceted stones. It contains cholesterol, calcium, salts of phosphate, carbonate, palmitate, proteins, and everything. Pigment stones are very small stones. It can be in black in color or greenish black. Often they can be sludge like. Next, only 10% of gallstones are radio opaque. This is a radiological appearance. In this picture, we can able to get on appearance like this is known as Mercedes-Benz sign or Seagull sign. Here, the center of a stone contains radiolucent gas, which is either triradiate or biradiate. That is why it is known as Mercedes-Benz sign or Seagull sign. Next comes the causes. The factors which alters the cholesterol to bile salt ratio, that factors will lead to gallbladder stone formation, mainly obesity, OCPs, ileal disease, ileal resection, high calorie intake, and Stasis and altered gallbladder function leads to gallbladder stone formation. And next comes an MCQ. Triple F or 4F leads to the risk factor. They are the risk factors: female, fertile, fat, 40 years. So this is the risk factor for gallbladder stone formation. So this is common in fat, fertile, 40, flatulent, female. And if we think about the infections, in bacteria, E. coli and Salmonella are the commonest, and in parasites like Clonarchus sinensis and Ascaris lambrycoides are often associated. Next comes an important MCQ, Moynihan's aphorism. It talks about the organisms, infective organisms. A gallstone is a tombstone erected to the memory of the organism within it. So infections are also the important cause for the gallstone formation. Next, we have a triad in gallstone. Not only in gallstone, it's a same triad. It includes gallstones, diverticulosis of colon, and hiatus hernia. DGH. D is diverticulosis, G for gallstone, H for hiatus hernia. We can remember like this: her girls diverted by the saint. Her girls is hiatus, girl is gallstone, diverted by the saint. Diverted is diverticulosis, by the saint is saint's triad. And the gallstone effects can be seen in gallbladder, CBD or intestine. If we think about gallbladder, it may leads to limey gallbladder. What is that? Sometimes gallbladder may be filled by toothpaste like material, which is a mixture of calcium carbonate and phosphate. And on plain X-ray, it looks like an opacified gallbladder, that is known as limey gallbladder. And the patients will present with biliary colic with periodicity, and this is the commonest presentation. Patients will have pain after meal, that is the commonest presentation. And also they will be having flatulent dyspepsia, discomfort in the abdomen, belching, heartburn after taking the food. And effects in the CBD, these are the secondary, and it may lead to pancreatitis, cholangitis and Merisi syndrome. Merisi syndrome is nothing but compression of CBD by stone from the cystic duct or choledochal fistula. In this picture we can able to see stone is present in cystic duct, that leads to the issues, so that is known as Merisi syndrome. And coming to the intestine, choledochoduodenal fistula causing gallstones. Ileus are intestinal obstruction. So this diagram is clearly explains about the complications of gallstones. It may leads to carcinoma. If it get rupture, may leads to abscess or rupture of gallbladder, Merisi syndrome, and a stone in the CBD, that may leads to pancreatitis. And if it forms the fistula, stone may seen in intestines, so that may causes gallstone ileus and related issues. Now Merisi syndrome. As we have already saw, gallstone impacts in the gallbladder wall and compresses it, causing pressure necrosis, which further gets adherent to the CBD wall. It eventually causes compression, then leads to the formation of fistula. Next comes the silent gallstone. This is asymptomatic stone in the gallbladder. Usually it is cholesterol stone and often single stone. Why it is known as silent stone? Because these patients will not be having any symptoms, and this will be accidentally discovered by ultrasonography. And this is common in diabetic patients, immunosuppressed patients, and gallbladder, and these patients are having high chances to develop gallbladder carcinoma. And we have completed today's discussion. We will be seeing some other gallbladder surgical conditions in next video. Thank you.